Welcome back to the deep dive. We are glad you're here with us. Today, we're staring into the face of a condition that's often misunderstood, very frequently misdiagnosed, and just devastatingly silent until it's almost too late.
It really is.
We're looking at chronic pancreatitis. And to kick this off, I want to borrow a really powerful image from the research stack we're working with today. It's a comparison that honestly feels more like poetry than pathology.
It's a striking comparison. It
Yeah.
really it sets the stage perfectly for the gravity of what we're about to discuss.
It really does. So the source material sets up this dramatic contrast between acute pancreatitis and chronic pancreatitis. It describes the acute form as something that screams.
Right.
It shocks the system. It's dramatic. It's the kind of thing that sends you straight to the emergency room because, it's impossible to ignore. It hits hard, fast, 10 out of 10 pain.
Exactly. It's a medical crisis happening in real time. It demands your attention. But chronic pancreatitis,
Yay, opposite.
it's the complete opposite. It doesn't scream. The source describes it as silent. It operates in the background, almost lurking in the shadows, just slowly scarring the organ, destroying its function, day by day, year by year.
And that silence is what makes it so incredibly dangerous, right? Because by the time the patient realizes something is really, truly wrong, the damage is often already done.
That's it.
The silence isn't safety, it's just the sound of gradual destruction.
That is the absolute tragedy of this pathology. The realization often comes way too late. We're not talking about a stomach ache that comes and goes. We're talking about a patient realizing they suddenly, can't digest their food properly. They're losing weight, sometimes rapidly, because the nutrients just aren't being absorbed. Or maybe they've developed diabetes seemingly out of nowhere.
Wow.
And the pain, when it finally settles in for good, it never really leaves. It's a slow-motion crash.
So our mission for this deep dive is to unpack exactly how that crash happens. We're going to look at the definition, the Robbins-style definition for those who love their pathology texts, and really understand why this isn't just, a longer version of the acute form.
Right. We need to understand the cellular villains.
Yes, and the autoimmune mimics that look just like cancer, and of course, the long-term outlook.
And we really have to focus on that key transition from simple inflammation to permanent scarring. We're going to explore the causes, especially the number one cause, and the specific cellular mechanism that involves these stellate cells.
And that word you mentioned earlier, irreversible.
And why this disease is irreversible, which is, a terrifying word in medicine.
Okay, let's get into it. Let's start with that definition. Section 1, the definition of no return. The source material is very, very specific about the wording here.
It is. And in pathology, every single word carries weight. The clinical definition given is prolonged inflammation of the pancreas associated with irreversible destruction of exocrine parenchyma, fibrosis, and eventual loss of endocrine parenchyma.
Irreversible. That's the key word you flagged. It really does feel like a slamming door.
It is the single most important distinction. In acute pancreatitis, even if it's really severe, the organ has the potential to heal. The tissue can recover.
It's a two-way street.
It's a two-way street. You can go into the danger zone and come back out. But chronic pancreatitis, that is a one-way street. Once that destruction happens, the function does not come back. You're dealing with permanent architectural change to the organ.
And looking at that definition, there seems to be a specific order to the destruction. You mentioned exocrine first, then endocrine. Can we break that down for someone who might not be looking at a histology slide right now?
Of course.
Yeah.
So think of the pancreas as kind of dual function factory.
Okay.
One assembly line makes digestive enzymes. That's the exocrine parenchyma. The other assembly line makes hormones, like insulin. That's the endocrine parenchyma. The source highlights the destruction of the exocrine part happens first. Following that, you get fibrosis, which is the scarring.
Right.
And then, usually in the later stages, you finally see the loss of the endocrine parenchyma.
So if we translate that into the patient's experience, first, your ability to digest food fails.
Exactly.
The factory workers who break down your lunch are, they're gone. And then later, your ability to control your blood sugar fails.
Slice. Digestion fails, then glucose control fails. It's a cascading failure of the organ's most basic functions.
And it's a cruel progression, really, because the patient might be dealing with malnutrition and horrible gut issues for a long time before all the diabetic complications pile on top.
That is just a brutal progression.
Yeah.
Now, before we get into the how and the why, who are we talking about here? Who is actually at risk for this? Well, in terms of epidemiology, it's not an incredibly common disease in the general population. The prevalence ranges somewhere between 0.04% and 5%, depending on the population you're studying.
Okay.
But the primary demographic that really stands out in the data is middle-aged males. That's the group where we see this most frequently.
Okay, so middle-aged males are the demographic target, which leads us perfectly into section 2, the usual suspects. What is driving this? If I asked you for the #1 driver of chronic pancreatitis, what would you say?
Without a doubt, and the source emphasizes this as a high-yield fact for anyone studying this, the most common cause is long-term alcohol use.
The alcohol factor, we hear about this with the liver all the time, but the pancreas seems to take just as much of a beating.
It does, but the mechanism is pretty interesting. And notice the phrasing long-term. This isn't usually the result of a single weekend of binge drinking, which might trigger an acute attack.
Right, this is a marathon, not a sprint.
Exactly. This is chronic, sustained exposure leading to chronic, sustained damage. It's the primary driver we see in clinical practice, bar none.
So how does the alcohol actually cause the damage? Is it just like burning the cells directly?
It's more of a multi-pronged attack. So first, yes, alcohol is a direct toxin to the acinar cells. Those are the ones making the enzymes. It causes a ton of oxidative stress.
Yeah.
But more mechanically, chronic alcohol consumption changes the very composition of the pancreatic fluid. It makes the fluid really, really rich in protein.
So that the juices get thick.
Exactly. They get thick and sticky. These proteins start to precipitate out and form these little plugs inside the tiny pancreatic ducts.
Oh, wow.
These plugs block the flow, they can calcify into stones over time, and they cause obstruction from the inside out. So you have direct toxicity plus a plumbing problem.
That's a nasty combination. But it's not the only cause. The notes categorize the causes into 4 main buckets. Alcohol is the toxic metabolic one. What are the others?
Right. So aside from alcohol, we have obstruction as its own category. This is where you have a long-standing blockage of the pancreatic duct that's not necessarily caused by those alcohol-induced plugs.
What's blocking it in these cases then?
Usually it's either calculyso, gallstones that have migrated and gotten stuck, or neoplasms, which are tumors.
A tumor.
Yeah. If you have a slow-growing tumor or a stone that blocks the main duct, you prevent the enzymes from exiting. This creates back pressure. The enzymes are trapped inside the gland, and eventually that pressure and inflammation lead to atrophy and scarring.
Okay, so blockage leads to scarring. That makes sense.
Yeah.
And category 3?
Category 3 is autoimmune injury. And this is a fascinating area where the body's own immune system basically identifies the pancreas as an enemy and attacks it.
We're definitely coming back to that.
Oh yeah, we're going to do a massive deep dive on that specifically later on because it's a master of disguise and a really critical diagnosis to catch.
And the 4th category?
Hereditary factors. The source notes that up to 25% of cases might have a genetic basis. This is a statistic that often surprises people because we are so conditioned to think of this as a lifestyle disease.
That's a huge percentage, up to a quarter of cases being genetic.
It really challenges the stereotype. For instance, mutations in the CFTR gene, which is the same gene involved in cystic fibrosis, can predispose someone to chronic pancreatitis.
And that ties right back to the thick fluid concept you mentioned, doesn't it?
It does, perfectly. The CFTR gene is responsible for regulating the salt and water balance in our secretions. If that gene is mutated, the pancreatic secretions become dehydrated and thick,
Leading to the same plugs?
leading to those same ductal plugs and obstruction we talked about with alcohol. So whether it's booze or your genes, the mechanism of clogging the pipes is often very similar.
So we have our causes: alcohol, obstruction, autoimmune, genetics. Now I want to get into the mechanics. Section 3, the fibrosis story. How do we get from a repeated injury to a hard, scarred organ? The source mentions a shift in dominance.
This is really the crux of the pathology. The proposal is that chronic pancreatitis often starts as repeated episodes of acute pancreatitis.
So one hit after another.
Right. Imagine you have an injury. You get inflammation. If that happens once, you'll probably heal just fine. But if it happens again and again and again, you start a chain reaction.
And that reaction changes over time from being like hot inflammation to something else entirely.
Exactly. Acute pancreatitis is what we would call inflammation dominant. It's full of immune cells, edema, swelling, neutrophils rushing to the scene. It's a hot battlefield.
Okay.
But chronic pancreatitis shifts to being fibrosis dominant. While you still have some inflammatory mediators present, the fibrogenic factors, the things that actually build scar tissue, take over the whole process.
So the body stops trying to fight the injury and starts trying to, wall it off with concrete?
That's a very good analogy. The source describes a clear progression. It starts with paralobular fibrosis,
Yeah.
so scarring around the lobes of the gland. This leads to duct distortion, which alters the secretions, leading to more injury. And eventually you get widespread fibrosis.
It's a vicious cycle.
It is. The organ essentially tries to patch itself up so many times that it becomes nothing but patch.
And there's a specific cellular villain in this story, isn't there? The notes highlight a star of the show.
The pancreatic stellate cells. These are the key players. In a healthy pancreas, these cells are just sitting there, quiet, in the periacinar space. They're essentially resting myofibroblasts. They store vitamin A and generally mind their own business.
So they're like sleeping giants.
Pretty much, but they don't stay sleeping. When there's a repeated injury, specific cytokines, which are distress signals, are released by the damaged cells in the immune system.
And those wake them up.
They wake them up. The source lists two major ones you absolutely need to know. TGF-beta, that's transforming growth factor beta, and PDGF, platelet-derived growth factor.
TGF-beta and PDGF. Let's assign roles to these. These are the alarm clocks.
They are the alarm clocks and the marching orders. TGF-beta is probably the most potent fibrogenic cytokine known to science. It basically tells the stellate cells, wake up and start building collagen. It drives the production of the scar matrix.
And PDGF, what's its job?
PDGF stands for platelet-derived growth factor. That is a proliferation signal. It tells the stellate cells, multiply. So not only are they awake and building scar tissue, but they are also cloning themselves to build it even faster.
So if we walk through the pathway provided in the source, it goes like this. Repeated injury leads to the release of TGF-beta and PDGF.
Right.
This activates the stellate cells. Stellate cells proliferate and deposit collagen.
That's a ton of it.
Collagen creates fibrosis. Fibrosis squeezes and destroys the acinar cells, the functional cells,
Oh, wait.
and the end result, pancreatic insufficiency.
It's a tragic assembly line. You're effectively replacing a complex, high-functioning biological factory with a block of inert scar tissue. The functionality is literally strangled out of the organ.
Which brings us to section 4, visualizing the damage. If a surgeon were to open up a patient or a pathologist is looking at this organ, what does it actually look like?
Well, grossly, meaning to the naked eye, the gland changes completely. It becomes hard. A healthy pancreas is relatively soft, lobulated, almost like a sponge.
Oh, yeah.
A chronic pancreatitis, pancreas feels like a rock because of all that fibrosis.
Yeah.
It's often shrunken and atrophic too.
And the ducts, you mentioned the blockage earlier.
The ducts are visibly dilated. Imagine a river that has been dammed up. It widens out behind the dam. The pancreatic ducts do the same thing, and they often contain calcified concretions. Stones. So you have a hard, shrunken gland with these dilated tubes filled with little white stones, sometimes called a chain of lakes appearance on imaging.
That sounds incredibly painful just describing it. What about under the microscope? What are the details there?
Histologically, you see a chronic inflammatory infiltrate around the lobules and ducts, but the absolute hallmark is acinar loss. The cells that make your digestive enzymes are just gone, they've dropped out. However, there is a fascinating mystery here that the source points out, and it has to do with the islets.
The islets, those are the endocrine part, right? The insulin makers. The second department of the factory.
Yes, exactly. Early in the disease, there is a relative sparing of the islets. While the rest of the pancreas is being destroyed and scarred over, the islets seem to survive, at least initially. They become embedded in the sclerosis, so they're trapped in the scar tissue, and they might even appear enlarged or fused together.
That completely explains why the digestion fails first and the diabetes comes later. The insulin factories are the last stronghold.
That's a great way to put it.
They're huddled together in the bunker while the rest of the building collapses around them.
Exactly. They hold out as long as they possibly can, surrounded by total destruction. It's a testament to the body's prioritization of blood sugar control, or maybe just a quirk of that tissue's resilience.
The source also mentions a specific signature for alcoholic chronic pancreatitis versus other types. Is there a way to tell just by looking?
There are definitely clues. The source notes that in alcoholic chronic pancreatitis, you typically see very prominent ductal dilation, intraluminal protein plugs, those clumps of sticky protein we talked about, and of course, the calcifications.
Those protein plugs sound key.
They are highly characteristic of the alcohol-induced pathology. If you see those on a slide, your differential diagnosis leans very heavily toward alcohol as the cause.
Okay, so that's the classic presentation. Rock-hard gland, stones, dilated ducts. But now I want to pivot to section 5, because this is the part of the research that felt like a medical thriller, the great mimic.
Ah, yes. autoimmune pancreatitis.
This sounds like an absolute nightmare scenario for a diagnostician. The source calls it a clinical trap. Why is that?
It's a trap because of how it looks on imaging. Both variants of autoimmune pancreatitis, or AIP, can present as a mass lesion in the head of the pancreas.
And when a doctor sees a mass lesion in the head of the pancreas on a CT scan, what is their first thought? What is the immediate fear?
Pancreatic carcinoma. Cancer. Specifically, pancreatic ductal adenocarcinoma, one of the deadliest cancers we know, with a notoriously poor prognosis.
So a patient could be told, it looks like you have a tumor. They prepare for the absolute worst, but actually, it's this autoimmune condition.
Yes, and the implications are just massive. If it's cancer, you might be looking at a Whipple procedure, a huge life-altering surgery where they remove the head of the pancreas, the gallbladder, part of the stomach, part of the intestine.
A massive operation.
Or, if it's inoperable, you're looking at palliative care. But if it is autoimmune pancreatitis, it responds beautifully to steroid therapy.
That is the punchline the notes emphasize. A mass in the head of the pancreas isn't always cancer. One is treated with major risky surgery, the other with a simple course of steroids.
Right.
Mistaking one for the other is a catastrophic error.
It changes the entire treatment plan. That's why differentiating them is a life-saving distinction. You do not want to perform a Whipple on a patient who just needed prednisone.
The source breaks AIP down into two types, type 1 and type 2, a tale of two types. Let's distinguish them so we know what we're looking for. What is type 1?
Type 1 autoimmune pancreatitis is actually part of a systemic disease. It's an IgG4-related disease.
Okay, what does that mean?
It means it's not just the pancreas. The patient likely has autoimmune issues elsewhere in the body, maybe salivary gland swelling, retroperitoneal fibrosis, or kidney involvement. It's a body-wide problem.
And what does it look like under the microscope? If we take a biopsy, what are the key words?
It has a very, very specific look. The source describes storiform fibrosis. Storiform means swirling, like a cartwheel or a woven mat.
Okay, storiform.
You also see something called obliterative phlebitis, which is inflammation of the veins that closes them off, and a dense inflammation that's super rich in IgG4 plasma cells.
Swirling fibrosis and IgG4, that's type 1, the systemic version. What about type 2?
Type 2 is different. It is restricted mainly to the pancreas. It doesn't really roam the body like type 1 does. It does, however, have an association with ulcerative colitis, a type of inflammatory bowel disease.
And the histology, how is that different?
The histology here is quite distinct. You see neutrophilic infiltrates. Neutrophils are a different type of white blood cell, usually associated with an acute infection. But here they are attacking the epithelium and the lumen of the medium-sized ducts.
The source calls these granulocytic epithelial lesions.
Correct. That's the technical term. And the key difference, the thing that really separates it from type 1, is that type 2 lacks those abundant IgG4 plasma cells. It's a totally different immune mechanism.
So to recap, type 1 is systemic, IgG4 dominant with swirling scars. Type 2 is local, neutrophil dominant, and gut related, but both respond to steroids.
Yes, generally speaking, the autoimmune forms respond to steroids, which is why making the diagnosis is so critical. If you give steroids and that mass shrinks, you just save the patient from the operating table.
That's amazing. It's real detective work at its finest. Now, let's move to section 6. The silent symptoms and diagnosis. We talked about the scream versus silence at the top of the show, but eventually the silence has to break. How do these patients describe their suffering?
There are two main patterns described in the source. First, you have patients who experience repeated attacks of mild to moderately severe abdominal pain. It comes and goes and is perhaps triggered by something.
Okay.
The second pattern is persistent abdominal and back pain. Just a constant gnawing pain that never really goes away.
Why back pain? That seems unconnected to the stomach area for a lot of people.
It's purely anatomical. The pancreas is a retroperitoneal organ. It means it sits way back in the abdomen, right up against the spine, and the nerve plexus is there.
I
So
see.
when it gets inflamed or scarred, that pain radiates straight through the back. It's very common.
And there are specific triggers that can set off an attack, right?
Yes. Excessive alcohol consumption is a major one for obvious reasons, but also overeating.
Overeating. Why would a big meal hurt the pancreas?
It all comes back to demand. When you eat a large meal, your brain tells the pancreas, hey, we have work to do, release the enzymes. So the pancreas tries to ramp up production.
Okay.
But if the ducts are blocked or the tissue is scarred, you are increasing pressure inside a closed system. and that pressure equals pain.
That makes perfect sense. It's like stepping on the gas when the tailpipe is plugged.
That's a perfect analogy.
Uh-huh.
And the source also mentions opiates as a trigger, which seems counterintuitive since they are painkillers and these patients are often in a lot of pain.
Right, you'd think morphine would be their best friend.
It is deeply ironic, but opiates increase the tone of the sphincter of Oddi. That's the little muscular valve that controls the flow of pancreatic juices into the intestine.
I see where this is going.
If opiates make that valve spasm or tighten up, pressure builds up in the pancreas. So the very drug you take for the pain can mechanically worsen the cause of the pain.
But there's just a cruel twist.
Yeah.
Now, we mentioned the silent progression.
Yes. Some patients, for whatever reason, don't have the significant pain. They are silent until the crash. And the crash is pancreatic insufficiency and diabetes mellitus.
So they present with the end-stage problems.
They present because they are severely malnourished or their blood sugar is completely out of control. The destruction of both the exocrine and endocrine functions is complete. They skip the warning signs and went straight to organ failure.
Diagnosing this sounds incredibly tricky, especially in those later stages. The expert notes mention something about enzyme levels being misleading. In acute pancreatitis, we look for high amylase, right?
That is the gold standard for acute attacks. High amylase lipase means the pancreas is inflamed and leaking enzymes into the blood. But this is a classic diagnostic challenge in chronic cases.
How so?
During an acute flare of chronic pancreatitis, you might see a mild elevation. But, and this is so crucial, later in the disease, the acinar dropout, the cell death, may be so severe that there simply aren't enough cells left to produce amylase.
So the test comes back normal, not because the pancreas is healthy, but because it's completely burned out.
Exactly. A normal amylase level does not rule out chronic pancreatitis. It might just mean the factory is already burned down.
Yeah.
There's nothing left to leak.
That removes a major clue for the doctor, so how do they catch it?
You have to look at the whole clinical picture. Imaging helps immensely. CT scans and ultrasound can spot those calcifications, the stones we talked about. A pancreas full of stones is a dead giveaway.
And physical clues?
And you look for physical clues.
Rob.
Dramatic weight loss from malabsorption, edema or swelling, which can happen secondary to hypoalbuminemia, low protein levels in the blood, because you aren't digesting and absorbing protein from your food.
So it's not one single test, it's a constellation of findings. High suspicion is required.
Absolutely. You have to connect the dots between the patient's history, the imaging, and their physical state.
We're heading into the final stretch here. Section 7. Prognosis and complications. We've established that this is irreversible. So what is the future for these patients? I mean, is it fatal?
I have to adopt a serious tone here, as the source does. It's not immediately life-threatening the same way a massive heart attack or acute hemorrhagic pancreatitis is. But the long-term outlook is, it's poor.
How poor?
The mortality rate is about 50% over 20 to 25 years.
50% over 20 years. That is a significant shortening of life expectancy.
It is, and it's not just about mortality. It's about morbidity, the quality of life. These patients suffer from exocrine insufficiency, which means chronic diarrhea and malnutrition. They deal with diabetes, which brings its own host of cardiovascular and neurological complications.
And the pain.
And they deal with severe, often intractable chronic pain that can lead to narcotic dependence and all the problems that come with that. It's a very difficult life.
The source also mentions pseudocysts as a complication. What are those?
Yes, pseudocysts develop in about 10% of patients. These are not true cysts, but they're collections of necrotic debris and enzyme-rich fluid that get walled off by fibrous tissue.
They sound dangerous.
They can be. They can become infected, they can rupture and cause massive internal bleeding, or they can grow large enough to compress adjacent organs. They are like little ticking time bombs sitting in the abdomen.
And finally, the question everyone asks about any condition involving chronic inflammation, the C word. What is the cancer link?
Chronic inflammation is a well-known breeding ground for cancer in many organs. Think of hepatitis leading to liver cancer. The pancreas is no exception.
So there's a risk.
For general chronic pancreatitis, there's a modestly elevated risk of developing pancreatic carcinoma.
Modestly elevated doesn't sound too terrible, but I'm guessing there's a caveat for a specific group.
There is a massive caveat. For those with hereditary pancreatitis specifically, those with a PRSS1 mutation or other high-risk genetic factors, for these patients, the lifetime risk of pancreatic cancers is startling. It's around 40%.
40%. That is almost a coin flip. That's incredibly high.
It is staggeringly high, and it emphasizes why understanding the cause, whether it's alcohol or genetic, is so important for long-term surveillance. If you know a patient has hereditary pancreatitis, you are watching them like a hawk, because that cancer risk is existential.
This has been a heavy deep dive, but an incredibly important one. We've gone from the mechanics of the cell to the clinical reality for the patient. Let's try to bring it all together.
Let's do a rapid-fire recap to lock this in.
Okay, key takeaways from our source material. First, the definition. It's not just inflammation, it is irreversible injury. Exocrine fails first, endocrine fails later.
Correct. And remember the mechanism. It's a shift from being inflammation-dominant to fibrosis-dominant. The key cytokines are TGF-beta, the builder, and PDGF, the multiplier. The key cell is the stellate cell, which transforms from a sleeping vitamin store into a scar tissue factory.
Visually, think of a hard gland, dilated ducts, and calcified stones, the chain of lakes.
And do not forget the great mimic, autoimmune pancreatitis. Type 1 is IgG4, systemic, and has that swirling store-form fibrosis. Type 2 is neutrophilic, local to the pancreas, and often gut-associated.
And crucially, both respond to steroids, which distinguishes them from cancer.
Yes.
And finally, the silence is dangerous. A normal amylase level doesn't mean you're safe. It might mean the damage is already total. The silence is just masking the destruction.
Precisely. That's the perfect summary.
Now, we usually end with a look forward. And the source material really leaves us on a bit of a cliffhanger here. We've talked about the scarring. We've talked about the inflammation.
It does. We've talked about how this chronic injury sets the stage. The fibrosis, the inflammation, the constant cellular turnover. It creates a background of a fertile soil that leads into very dangerous territory.
The source explicitly teases the next logical topic. We've dealt with the scarring, but what grows out of that scar?
The next phase of pathology involves non-neoplastic cysts, neoplasms, and the most feared diagnosis in all of abdominal pathology, pancreatic carcinoma.
So while chronic pancreatitis is silent, it may just be the quiet precursor to a much louder, much deadlier problem. That is a sobering thought to end on.
It is, but understanding the precursor is the first step in catching the successor. Knowledge of the silence helps us anticipate the scream.
Absolutely. Thank you for guiding us through the silence and the mechanics of the pancreas today.
It was my pleasure.
And to you listening, thanks for diving deep with us. We'll see you next time.